Welcome to this video tutorial on epilepsy. With an estimated incidence of 50 per 100,000 per year and a prevalence in the UK of 5 to 10 cases per 1,000, epilepsy is an important neurological disease. NICE clinical guidelines tell us that the annual estimated cost of established epilepsy is £2 billion. Let's have a definition. What is epilepsy? Epilepsy is the recurrent tendency towards spontaneous, intermittent, and abnormal electrical activity in part of the brain, and this manifests itself as a seizure. Now, epilepsy is characterised by 2 or more seizures. A seizure is any clinical event caused by an abnormal electrical discharge in the brain, whilst epilepsy is a tendency towards this. So when a normally functioning cortex sends an excitatory message from one neuron to another, how do we stop all the neurons in that area from being activated, from being stimulated? Well, very conveniently, we have recurrent and collateral inhibitory circuits which run alongside the excitatory circuits, and these will inhibit the neighbouring groups of neurons from becoming overexcited. So really important to these inhibitory circuits is the neurotransmitter GABA, so gamma aminobutyric acid. So in the cerebral cortex of a patient with epilepsy, there's a hypersynchronicity in the repetitive discharges. So what this means is if we're trying to get from A to B, then in a patient with epilepsy, we're more likely to get from A to B and A to K and A to C and A to D in addition. So accountable for this is the fact that there is what we call a paroxysmal depolarization shift. So what this means is the transmembrane potential is reduced. So the cells are more easily excitable. Then, in addition to the hyperexcitable cells, we also have a reduction in the inhibitory systems. Unfortunately, kindling occurs. Now, kindling is the way in which the cells will undergo changes. So once an epileptic discharges have occurred within the cells, then they'll undergo morphological and physiological changes, and these changes will make them more likely to produce subsequent abnormal discharges. So a patient is more likely to have another seizure after their first. Seizure type. Seizures are often divided into either a partial or focal seizure or a generalised seizure. So a partial seizure is when the neuronal activity that is abnormal is limited to one part of the cortex, whilst a generalised seizure is where that abnormal electrophysiological activity is spread, so it involves both hemispheres simultaneously and synchronously. Considering a primary generalised seizure, the origin is not a single focus. Instead, it's synchronous throughout the cortex, and about 40% of all seizures are primary generalised. The location of the abnormal electrical activity will determine the symptoms of that seizure. If the patient remains conscious, then we refer to the seizure as a simple seizure. If a patient loses consciousness during the seizure, then we refer to this seizure as a complex seizure. A partial seizure that spreads to the diencephalon and then throughout the remainder of the cortex will lead to a secondary generalised seizure. A specific type of generalised seizure we often hear about is a tonic-clonic seizure. In a tonic-clonic seizure, the patient will become very rigid, so this describes the tonic phase, where they become unconscious. They often fall to the ground and may injure themselves. Sometimes there may be respiratory arrest, and so the patient stops breathing and becomes cyanotic. This may be detailed in the description of an observer that the patient became blue and stopped breathing. Then a few moments later, the patient will become clonic, so the rigidity relaxes in phases. And this is what produces the clonic jerk seen in a tonic-clonic seizure. But not all patients will have the clonic phase, so not all of them will be seen to be jerking. An aura will often precede the seizure. The aura is caused by a partial seizure. The symptoms that the patient will experience as an aura before they have the tonic-clonic seizure will be determined by the location of the partial seizure. The partial seizure then becomes a secondary generalized seizure, and a tonic-clonic seizure is experienced. Following any generalized seizure, a patient will usually take a little while to come back around. They'll tend to be quite confused and disorientated initially, and they may have disturbance to the memory regarding what's happened. So this might be prior to the seizure, and therefore they cannot remember the aura. Very severe headache will often follow a generalized seizure, and the patient will just want to sleep. In a generalized seizure, there will often be tongue biting and urinary incontinence. Absence seizures are a type of minor seizure, and they resemble complex partial seizures. In considering their etiology, they're a type of primary generalized epilepsy, so the generalized absence epilepsy of childhood, known as petit mal, can experience absence seizures. Petit mal will always occur in childhood. The seizures will resemble complex partial seizures, but they will be more frequent, they will be more brief, and they won't have the same post-ictal confusion that the complex partial seizures have. A quick word on atonic seizures. These involve a brief loss of muscle tone, and they can often result in a person falling over, but that doesn't necessarily mean that there will be a loss of consciousness. There may or may not be a loss of consciousness in atonic seizures. These types of seizures only occur in people with epilepsy syndrome, so they don't occur independently. Seizure etiology. Primary generalized epilepsy almost always presents in childhood or adolescence. There's often a substantial genetic predisposition. Amongst the categorization of primary generalized epilepsies are childhood absence epilepsy, which occurs, the age of onset is between 4 and 8 years, and that has an incidence of 6 to 8 per 100,000 people. There's juvenile absence epilepsy also, with a slightly lower incidence of 1 to 2 per 100,000, and this occurs at an older age of 10 to 15 years. There's also juvenile myoclonic epilepsy, with a mean age of onset between 15 and 20 years. And then there's general tonic-clonic seizures, which are the most common, with an age of onset between 10 and 25 years. Considering the etiology of secondary generalized epilepsy, there may be a genetic cause, such as inborn errors of metabolism or storage diseases. Hydrocephalus, cerebral anoxia, or cerebral birth injury may be a cause. Some drugs may cause secondary generalized epilepsy. Antibiotics such as penicillin, isoniazid, and metronidazole may be accountable for the secondary generalized seizure, as may some antimalarials, cyclosporin, or cardiac antiarrhythmic drugs. Amphetamine or alcohol withdrawal can cause a secondary generalized seizure, and toxins such as heavy metals like tin or lead, organophosphates. Of course, we need to consider metabolic disease in the cause of secondary generalized epilepsy, so hypoglycemia, hypocalcemia, hyponatremia, or hypomagnesemia. Even organ failures such as liver failure or renal failure can cause secondary generalized epilepsy. In a patient who's recently had meningitis or post-infectious encephalopathy can be a cause of secondary generalized epilepsy. Inflammatory conditions such as SLE or multiple sclerosis, although multiple sclerosis is an uncommon cause of secondary generalized epilepsy. Partial seizures may be caused by trauma. This may be trauma induced by neurosurgery. They may be caused by tumours, both primary and secondary tumours. They may have an inflammatory cause, such as sarcoidosis or vasculitis. They may be infective, so things like toxoplasmosis, a cerebral abscess, a subdural empyema, or encephalitis. Cerebrovascular diseases such as intracerebral hemorrhage, cerebral infarction, or AV malformations may cause partial seizures. Also consider some of the genetic causes of partial seizures, such as tuberous sclerosis, neurofibromatosis, and von Hippel-Lindau disease. Investigation. So what investigations would we like to do in a patient presenting with a seizure? Obviously, assuming that the patient is now stable, we'll start with the basics. So let's take some bloods. A full blood count to look at the white cell count for any infection. We can look at the erythrocyte sedimentation rate and the C-reactive protein for any inflammation. Let's consider metabolic disorders. So we'll do U's and E's, liver function tests, blood glucose, serum calcium and a serum magnesium. A CT or MRI to look at whether there's a structural lesion. A chest x-ray or CSF examination if we suspect an infectious disorder. Serology for syphilis, HIV or collagen diseases might be necessary. In considering the type of epilepsy that might be present, we might consider standard EEG, so an electroencephalogram, or a special electroencephalogram, so an EEG with special electrodes, a sleep EEG, or to explore whether there's an epileptic nature to the attacks. The patient may have an ambulatory EEG, or they may be brought into hospital to have video telemetry. Manage. Let's start with conservative management. Education is really important for patients with epilepsy because they have to be able to understand, firstly, what their epilepsy is so that they can come to terms with the condition. Of course, very importantly, they need to understand the nature of their epilepsy and whether there's anything that they can do to reduce the chances of them having a seizure. They need to be informed about the risks involved in certain behaviours. So a patient with epilepsy may not want to be working at high heights, for example, or taking very deep baths on their own, because if they were to have a seizure, then they'd be at a greater risk. Educating the family and the friends can be very important so that they're able to perform first aid when necessary during a seizure. Advise a patient not to cycle until at least 6 months has passed where they've been seizure free. And of course, all of these things will be done with the support of an epilepsy specialist nurse, so an ESN should be integral in the care of the patient with epilepsy, both to support the epilepsy specialist and the generalists. In the UK, there are regulations on driving for patients with epilepsy. After a single seizure, the patient should not drive for 1 year. If after that year there has been no recurrence of the seizures, then the DVLA will restore a full licence. In a patient with epilepsy, if they have been free of all types of seizure for 1 year, or the seizures are exclusively during sleep for at least 3 years, the DVLA will restore the licence. The licence will require renewal every 3 years thereafter until the patient is 10 years seizure free. Then their DVLA licence will no longer need reviews. If a patient is being taken off their anticonvulsant medication, they cannot drive for 6 months after the withdrawal of the medication. They will then be given their licence back provided that they have not experienced any seizures within that 6 months. With regards to vocational drivers, so heavy goods drivers or public service vehicles such as bus drivers, train drivers, the DVLA do not permit licences if any seizure has occurred after the patient was aged 5 years. They don't allow a licence to be given unless the patient is off medication and is seizure-free for more than 10 years. So a few more methods of conservative management. We want to advocate against drug use and alcohol use because these can precipitate a seizure. We want to advise the patient to lead a healthy lifestyle, and we could also recommend some support groups. Medical treatments. Treatment with anti-epileptic drugs, AEDs, is generally recommended after a second epileptic seizure, and it's generally a specialist who will initiate these medications. It may be appropriate for AED therapy to be considered after a first seizure if the child or young person or adult has a neurological deficit, the EEG shows unequivocal epileptic activity, the patient and perhaps their family consider the risk of having a further seizure unacceptable, our brain imaging shows a structural abnormality. The pharmacological treatment of focal seizures. The first line is carbamazepine or lamotrigine. Second line, if carbamazepine or lamotrigine is not suitable, levetiracetam, oxcarbazepine or sodium valproate should be used. So I'm going to talk you through a really easy way to remember the treatments for a focal seizure. So first line, first word is focal. So we write out focal loss. The C is for carbamazepine. The L is for lamotrigine. So their first line. Second line, we use the word loss. So levetiracetam for the L, oxcarbazepine and sodium valproate are the options for the second line treatment. How do we remember that lamotrigine is the first L and levetiracetam is the second L? Well, A comes before E in the alphabet. For the treatment of a newly diagnosed generalized tonic-clonic seizure, the first line is sodium valproate. Second line, if sodium valproate is unsuitable, is lamotrigine. If the person has myoclonic seizures or is suspected of having juvenile myoclonic epilepsy, then be aware that lamotrigine may exacerbate myoclonic seizures. Carbamazepine or oxcarbazepine may be considered, but again, there's a risk of exacerbating myoclonic or absence seizures with these medications. So absence seizures, we just write out absence, and this has got an E in it, so we're going to go with ethosuximide as the first line, and then the second line is sodium valproate.
Hi, my name is Nazir Mirza. I'm a clinical lecturer at the University of Liverpool and also a specialist registrar in neurology at the Walton Centre for Neurology. So I've been asked to talk to you briefly about research challenges in epilepsy. There are lots of research challenges in epilepsy, and I'll highlight 3 which I personally feel are most important. So the first challenge is finding the right drug for the right patient. There are lots of anti-epileptic drugs, but they are not equally effective for all forms of epilepsy. So one way of meeting this challenge is to conduct clinical trials. And the Department of Epilepsy within the University of Liverpool is at the forefront internationally of conducting such clinical trials. and the department is led by Professor Tony Marson. An aspiration for the future is to practice precision medicine or personalized medicine. In this form of medicine, one aims to predict before starting an anti-epileptic drug whether it is going to be effective for your particular patient. In order to do this, we need to analyze the DNA from lots of patients with epilepsy and understand more about the DNA changes and how they might be linked to response to anti-epileptic drugs. There are large international consortia which are working to analyze DNA from patients from thousands of patients with epilepsy, and the University of Liverpool is very much a part of these consortia. The second challenge I would highlight is treating patients who don't respond to any anti-epileptic drugs. So a third of patients with epilepsy continue to have seizures despite being treated with maximal doses of multiple anti-epileptic drugs. These people have drug-resistant epilepsy. Why they have drug resistance is not really known. And the Department of Molecular and Clinical Pharmacology within the University of Liverpool is investigating the mechanism of drug resistance using various different techniques. So I myself am involved in this research, and the research that I do involves taking epileptic brain tissue from such patients and analyzing the DNA and RNA in this brain tissue to try and find out the mechanisms underlying drug resistance. The hope is that in the future, with such research, we'll be able to identify new drug targets and new drugs which will allow us to be able to treat such patients. The final challenge that I will highlight is ensuring that anti-epileptic drugs do not cause harm to any of our patients. On the whole, anti-epileptic drugs are very safe, but rarely they can cause life-threatening side effects. People can be allergic to various anti-epileptic drugs, and they can cause serious adverse reactions which sometimes can even be life-threatening. Again, the University of Liverpool, the Department of Molecular and Clinical Pharmacology has done some outstanding research in finding genetic characteristics which increase the risk of an allergic reaction to one of our most commonly used anti-epileptic drugs. And the hope is that in the future we will be able to find genetic markers which we can test for any of the anti-epileptic drugs to predict whether a patient is going to have an allergic reaction to it before we give that drug to the patient. So I'll finish there. But as I was saying, there are lots of challenges in epilepsy research. These are the three which I personally feel are most important. And if you would like to be involved in any of this research, then please feel free to drop me an email or just stop me on campus if you see me, and we'd love to get you involved in any of these research projects.